Welcome to Personal Reflections on 35 Years of Cancer Clinical Trials, a conversation with Elizabeth Eisenhauer. I'm Janet Rossant, and I'm President and Scientific Director of the Gairdner Foundation. And I'm really thrilled to be kicking off Gairdner Science Week 2021 with this event. Dr. Eisenhauer is the recipient of the 2021 Canada Gairdner Wightman Award for investigation of new cancer drugs and delivery approaches, leading change in cancer clinical trials and establishing new standards of cancer treatment that have impacted patients around the world. So Dr. Eisenhauer is really an icon in Canadian science and clinical research. Her extensive research contributions and leaderships within the field of cancer care in Canada have influenced and advanced the conduct of clinical trials internationally. So I'm looking forward to hearing about her journey. Welcome, Elizabeth.
Thank you very much, Janet. It's a pleasure to be here with you.
Well, it's a pleasure, it really is a pleasure to have this conversation and to talk a little bit about your career and the impact, particularly of clinical trials, on health in cancer and, of course, perhaps more broadly. So you received a Wightman Award this year for your personal work on investigative clinical trials for new cancer drugs and delivery approaches, but also for your broader leadership within the Canadian Clinical Trials Group run out of Queen's University. So I wanted to talk a little bit about clinical trials because I think many of us understand the importance of clinical trials, but many of us don't really understand the process of setting up a clinical trial or how important it is that they're properly designed, powered, and really that the results are clear and impactful. Because obviously some people make discoveries in the lab, they discover a new target, they even get to the point of having a potential drug, and then they go, oh, well, now we'll just send it to clinical trials. And of course, some things work and some things don't, but that clinical trial step is really, really critical. So tell us about the process.
Well, this is a great question, and it's one that this isn't the first time I've been asked this question. I think there's a perception amongst some that the really hard work happens in the lab in sorting out the targets and the experiments to show promise for new agents, and that it's pretty formulaic then to just flip a switch, move it into the clinic, and find out in a few weeks or months if something works. And it's actually a little bit more complicated than that, as you might imagine. Clinical trials for new agents, tend to focus on one of three big questions about the biology of the drug that you're studying, about its preliminary evidence of anti-tumor activity, or really whether it has any signs of efficacy and with what cost in terms of safety to patients. And so depending on which phase of investigation you're beginning, I always say the most important thing to have clear before you start a trial is what is the question you're trying to answer. And that question will vary depending upon the phase of development. It will vary depending upon the context in which you're studying a new drug. If it's the first in human use, it's a very different first question than if you are really saying this has been around, now it's time to really ask, does it make a difference? Should it substitute for standard of care? So getting the question right, partnering with experts, and those will include clinicians in the field, but also the scientists, the pathologists, the radiologists, who are intricately related to the kinds of analysis and questions that you're going to have. So get the question right, and from the question flows almost everything else. It will tell you which patients. So a question around, let's say, a new drug that might replace the hormones currently used in breast cancer treatment. And is it actually affecting the hormone pathway that you think it will? Well, clearly you're going to be wanting to look at breast cancer patients. You may be wanting to look at those who exhibit characteristics on their tumor of certain hormonal receptors. And you may want to look at those who've been previously treated with a hormone or have some other marker that the lab science tells you is likely to predict the best population for using the agent. The question also helps dictate the design of the study and the endpoints. So if your question is about, does this new drug palliate bone metastases in prostate cancer? and you choose an endpoint of tumor shrinkage, you might be able to describe whether the drug causes shrinkage of tumor, but you won't be able to describe whether any patients actually experienced amelioration of symptoms. So the endpoint matches the question. And then the final thing is really the design. If you're looking at an endpoint that could happen by chance in the course of the biological evolution of a disease. So, for example, some patients' symptoms improve over time because of all the other things we do. Some patients' disease will seem to grow quickly, then slow down. And that's just part of the normal course of how cancer proceeds. If you have questions like that, then you need to embed in the design a control arm to make sure that observations you are collecting are really not due to what would have happened anyway to those patients, but reflect an impact of the drug or the therapeutic intervention that you're testing. So starting with the question and using that to guide who we're treating, what patients, what markers in their tumors, and what endpoints and what design are kind of the sort of bedrock of where we go. I could talk a lot about this. I'll only make one more point before I let you interrupt. And that is, even when you think you got all that right at the beginning, during the course of the study itself, you may have to do some course corrections. So thinking that you are going to study a certain dose of a drug in a certain schedule, and as you get going, new information might come from another study that a different dose or a different schedule is actually optimal. And you may need to reformat your protocol, alter your design and questions, and restart. Unexpected safety information coming along the way will also lead to that notion that you might need to amend your protocol, amend the way you're doing the work, monitor differently, and so on. So you start out as good as you can, but along the way, it isn't just you press a button and look at the end. You continually monitor what is happening in the study, what is happening around the context of that disease or drug internationally, and you use that information to improve or ameliorate the study that you're doing, so that at the end you can say, we answered the question we did, and we did so taking into account whatever new information along the course of the trial came up that was relevant.
So that's a great description of the whole process, which makes it, I think for all of us, it's incredibly complicated and layered process with multidisciplinary input. But of course, the other important thing about clinical trials, which the non-expert gets worried about, is this business between recognizing that that negative results are just as important as positive results,
right,
and this sort of feeling that that being an unbiased trial is really, really important. And it seems to me that certainly CCTG has got a very important part there to play. We want to assess drug A versus drug B, and you know what? Drug A is no better than drug B, and you have to be able to deal with those negative results and present them fairly.
I think that's true. And although it may sound paradoxical, actually doing trials in a multiple institutional way helps remove some of that attention and bias. If a trial is conducted only within one institution, what you can't account for is the views of the investigators there and how they might use those to select specific patients for the study that are still compliant with the entry criteria, but that aren't as generalizable as if you had multiple centers and investigators enrolling patients. So more generalizable, more likely to be reproducible. And the other aspect of bias, of course, is some trials have to be blinded, because we can be influenced in the decisions we make and how we interpret what's happening to patients based on what we know they're getting. And in early phase investigations, that is not as much of an issue as it is in late phase trials, where if you were especially looking at something that might be subjective as an endpoint, like quality of life or pain management, knowing that you're on a really exciting new drug may have some impact on how you perceive those symptoms or how your physician might So having some blinding around some trials will also reduce bias.
Yeah. And so multi-centered trials are important, and I guess that's the clinical trials group is
Exactly.
really leading that in Canada.
Yeah, and it also gives you the power, not in the statistical sense, but in the absolute sense, the power to address questions much more quickly, because some of the trials require hundreds or thousands of patients, and being able to do that in a wide network speeds the development. You also mentioned about the importance of negative results, and I think that's not just important for at an individual trial level. If we think this is the right path to follow and we find out that, whoops, it's not, finding that sooner rather than a gazillion other studies looking at exactly the same thing that started is important, because it's wasteful of resources and it teaches you something. But in terms of what we're looking for to guide therapy, sometimes understanding what not to do for a patient is very important. And we do that all the time. We don't talk about it. One of the reasons, and I use the hormone receptors in breast cancer, one of the reasons we want to know in a woman with breast cancer what hormones or surface receptors they experience is not just to guide what we will offer them, but what we won't, because we know it will fail. So not giving someone with ER positive breast cancer a hormonal agent, an estrogen or an anti-estrogen, spares them the side effects. It doesn't guarantee that the woman who is hormonal positive will benefit, but it removes from considerations people whose only outcome of that treatment would be side effects with no possibility of benefit. So knowing who not to treat and what not to treat with becomes an important way of navigating where to go with treatment in cancer.
And I guess that takes you to the whole sort of precision medicine
Exactly.
issue, trying to really tailor the treatment to the person's genetic background, their clinical history, their environment, everything else. So it's very, very important. And cancer, of course, leads the way in precision medicine. Okay, so tell me a bit about some of the trials that you've been involved with, and give us some ones that have changed practice worldwide. What are you most proud of in terms of the trials that have come out?
I'll preface this with saying that there's no trial that I did. It was always a we in front of this. Because, as we say, we're part of a network, a collaborative group, not just in Canada, but internationally. So some of the early trials, you'll have to remember early on, I was really primarily leading phase 1 and 2 trials, which are only going to give you an idea of what might work. It's not going to be the definitive test. But early on, the IND program and the clinical trials group was the first to study in Canada a drug called CBDCA, which then became known as carboplatin, in ovarian cancer. And it showed a response rate that was reasonably respectable in recurrent ovarian cancer, and less toxicity than cisplatin, which had been up till that time the compound used. That trial led to the design of a frontline trial done by the CCTG, which embedded carboplatin into the first line of treatment. Shortly after that, the trial with paclitaxel that we did in ovarian cancer was launched, and that was a study that, and paclitaxel is an interesting story with some Gairdner overtones, of course, because it was a drug that was an extract of the bark of the Western yew. So a pretty, like, who on their right mind would think something in a tree bark would help cancer? But in the 60s, the US National Cancer Institute was looking at all sorts of natural products, and they found the extract of the bark of the Western yew stopped cells growing in Petri dishes. And it looked like it was just another, microtubular poison. So it was kind of shelved because we already had a few of those, like vincristine. And it was Susan Horowitz, who was the 2019 Gairdner International winner, that showed that this was a different kind of tubular poison. It did something almost the opposite of vincristine. And the fact it had a novel mechanism took it into the clinic. So when it was in the clinic, boy, did it hit some bumps in the road. It caused cardiac toxicity. It caused these terrible hypersensitivity reactions. So people who were getting the infusion would suddenly become short of breath, turn red, some collapsed, pain in their back, really miserable, and it almost kind of killed the drug until some maneuvers around lengthening the infusion and starting some pre-medication were implemented. And we got involved in Canada by saying, well, surely we need some randomized data on how best to use this drug. So I, with a couple of other people, designed a bifactorial randomized trial looking at 2 infusion schedules and 2 doses. And again, in the spirit of getting there fast, we engaged with colleagues in Europe to join the trial. So that was the first international one. And that so-called OV9 study was my first randomized ovary trial. And it really changed practice because we found, much to everyone's surprise, that giving shorter infusions not only was safe to do with the pre-meds, it actually was safer because it didn't cause the extreme myelosuppression. And so that shorter infusion and a higher dose, which were the recommendations coming out of that, became adopted everywhere, led to a frontline trial in ovary with our group and the Europeans, which again changed practice and embedded paclitaxel in frontline treatment. I'm lengthy about those 2 examples because ovarian cancer was where I really became most involved. But other trials I've been directly involved with that have changed practice are trials looking at the anti-metabolite pemetrexed in lung cancer, which again we found to be active. We combined with platinum and it went on to be used in lung cancer. A trial that we designed together with the Europeans in glioblastoma of a drug called temozolomide, which improved survival in that terrible disease, not by a huge amount, but by enough that it did change practice. And the clinical trials group writ large has also been involved in trials of epidermal growth factor receptor inhibitors in colon and lung. Both of those practice-changing trials leading to the first marketing approval of cetuximab and erlotinib, respectively. And more recently, trials in pancreatic cancer in collaboration with the French national group, which have changed sort of the approach to adjuvant treatment in pancreas. There's also several in breast and so on and so forth. Important to mention that not all the trials the clinical trials group did that has had an impact on practice were about drugs. Some of them were also about radiation treatment. So Tim Whalen and McMaster led a trial in breast cancer adjuvant radiation treatment, which changed practice, and some surgical studies as well.
Yeah, so it's had a broad impact across all aspects of cancer treatment. And obviously CCGG has been funded for many years by the Canadian Cancer Society. I mean, of course, prior to that, it was part of what was then called the National Cancer Institute, which of course was funded in turn by the Canadian Cancer Society. So it's been around for a long time, and it's had a lot of support from CCS and from other institutions and agencies. So it's a Canadian success story, I would say, but it's also supported by patients, donors, people who give money to support cancer research.
Yeah, and I have to, I'm glad you brought that up, because the Canadian Cancer Society has continuously, since 1980, provided a core grant to support the Canadian Cancer Trials Group. Without that, there's no government agency that's done that. In most other countries, it's government that supports these groups, but in Canada, it's charity, by and large, with project funding from CIHR, and also some support from the U.S. National Cancer Institute, because we collaborate a lot with them. And of course, for some studies that involve a specific agent from pharma will contribute some funds to allow us to do the trial. But it's a real tribute to the Cancer Society, whose donors have wanted to invest in research that eventually will make a difference to patients' lives. And it's a fantastic story about how we can easily connect the dots, at least with respect to the impact the CCS dollars flowing to the CCTG have made.
Yeah, I think it really is a great story, and it is a real. We have to acknowledge the people out in the field, the donors who just give money to cancer research
Yes.
every year and buy their daffodils. So it's really important. So you received the Canada Gairdner Wightman Award. How important is that to you and to your team? How did you feel when you got the award?
Oh, well, you made the phone call to me. I was a little bit speechless, which, as you can tell in this conversation, is unusual for me. I was surprised, humbled, and honored that the work that I've been part of in the clinical trials arena has been recognized by this award. I know my colleagues at the clinical trials group were just delighted. And I'm hoping that through my words today and in the Gairdner Week presentations, it's really clear that this has always been about collaboration and teams. And while I had the honor of being the spokesperson or the director of the New Drug Program for many years, it really was enabled by this extraordinary culture we have in Canada with oncologists, with basic scientists in the cancer space wanting to make a difference. So I was happy for myself, but happier yet for the team of people that made this work happen and for the patients who volunteered to make a difference and did.
Mm-hmm. Absolutely. And certainly that was part of the recognition, was really recognizing absolutely the teamwork behind everything that goes on. So sort of in that regard, and you look back on your career, role models, mentors, important to you at different stages?
It's interesting because I've sometimes called myself an accidental oncologist or an accidental cancer researcher. Many people have a dream or a vision early on what they want to do. And as I look back on the narrative of my life, I realize it was a lot of chance events that led me there and a lot of important interactions with people. So in medical school, by chance, my clinical skills teacher in second year was a hematologist called David Ginsburg. And I just thought the world of him. He was educated, at least in part, in Edinburgh, and he brought that sort of almost Conan Doyle-like approach to problem solving. And hematology is a perfect specialty for that because there's a very logical tree of how you work through problems and come to an answer and diagnosis. And he was inspirational to me and led me into hematology. And in hematology at the time, I guess I date myself, there was no oncology subspecialty in Canada. But over the course of my years in training, it became clear that as cancer drugs were coming out, it fell to the hematologists to see cancer patients. So I got introduced to cancer mostly because I chose hematology. And I got introduced to the notion of clinical trials because Queen's managed to recruit this hematologist called Joseph Pater, who applied for and got the position of director of the clinical trials group. And he said to me one day, how about you come and work for us for 2 or 3 years and we'll see what happens. And that, of course, was the change of everything. So mentors that made a difference, of course, my clinical teachers like David, like Joe, but also just the family context in which I grew up. It was a bit weird to be thinking about going into medicine at the age of 10, which I was. But instead of my parents saying, oh, well, you're a girl, you can't do that, they said, good for you, go for it. And so all along the way, I was encouraged by that kind of support and finding my feet in the area of clinical cancer trials seemed to be the culmination of a lot of little accidents and chances along the way, but also opportunities that I was happy to take advantage of.
That's great. I mean, serendipity plays a part in everybody's life, right?
Exactly.
So and whenever I have these conversations or talk to famous scientists, people have this idea that, you knew exactly what you're doing, you just go down the straight path. It's never like that at all. It's always a very winding path and a lot of coincidences and accidents.
Yes. Well, and as women in the professional medical field, we often get asked about how did you decide ABC? How did you decide when you were going to have a child?
Right.
How did you decide you wanted to do this and that? And you look back and you think, are there really any wrong decisions that you can make? It's only by trying to weigh things logically, yes, but also a little bit of the gut and heart going into those decisions at the time lead you forward. I don't think many people have an end goal of, I want to be president, or I want to lead the Ontario Cancer Institute. They follow their nose with their curiosity, with what challenges them, what gives them a sense of fulfillment, and what on a daily basis brings them into contact with people they like and that are fun to work with. And all of those things conspire together to kind of help you carve a bit of a path.
Yeah.
And I just feel privileged, really, that I lived in a time and a place where paths that I followed were even possible.
Yeah, you mentioned sort of, being a woman in medicine. Have you had challenges as a woman scientist? I mean, how did you face those challenges and overcome them?
I don't know. Either I was pretty thick, or, as I prefer to think, I really didn't face a lot of pushback because I was female as a medical student, as a trainee, or as a junior faculty member. I think there were obviously some changes afoot. I was the first member of the Department of Medicine who was female at Queen's. I was the first resident in the internal medicine program that had to inquire about, do we have maternity leave? Because no one pregnant had ever been in the program before. But I was never, I never felt people treated me as stupid or beneath them. And I was supported, and it seemed normal to do the things I did. And I know that story, again, is reflective of some privilege, also a bit of chance of the people who were around me and who were the leaders of those various departments and programs at the time. If anything could have been changed, it would have been nice to see a little sooner the opportunity to job share or role share in the science space, because you're either all in or not. And even today, it's challenging to be half of something, to be half of a parent and half of a scientist. So, but I actually think that even that has changed somewhat, and men in the field as well as women are both talking more about wanting to achieve a better balance, work-life balance. But it's hard. It's hard to let go of things that you want to get done.
Right. Yeah. Yeah. I mean, it is an ongoing balancing act for sure. So what would be your advice to young scientists today coming into any field, but particularly perhaps into clinical research?
Well, I suppose the advice starts with really educating yourself around the area that you think you want to be in, and to learn about it. Just seek out potential mentors, to seek out opportunities to experience that life, because the imagined life and the real life are often not terribly well connected. I would want them to consider the why of them wanting to do this, because people who have an idea about why they want to be in a certain field may have illuminated to them that there are other opportunities to contribute in the way, or to study, or to pursue careers that satisfy that why without that one thing. And I always think it's important not to be too monoclonal in thinking about where you want to go. If you want to be in a field that helps people, well, there are hundreds of fields that help people, but why this one? And are there others that might satisfy you? I suppose it would also be give yourself the time you need to make the decisions that are right. Don't, look before you leap. Working in cancer research is very competitive. If you're the kind of person who likes to be friends with everybody, it can be a challenging field, because in some way there's a lot of competition still in this area. But but being educated, finding mentors, understanding your own motivations, also not feeling that a decision you might take cannot possibly be reversed. You don't get on a train in Kingston and get off at Vancouver. There are stops along the way. So being prepared to change course if it seems right or if there are other opportunities that come up. So it is definitely challenging to provide that mentorship because all those things sound extraordinarily vague. They don't start with get a PhD in this subject and then apply to this lab or go and work in this hospital. And that is because I actually don't think that those are the recipes that tend to work.
Well, I think that's probably the right sort of advice, which is sort of follow your nose, follow your passion, and be committed to a pathway, but be prepared to take a different route if a different route opens up, right?
Yes.
So,
and know a few wise people who you respect,
yes.
who can be the place where you bounce ideas off, not so they can tell you what to think, but they can tell you how to think and how to make some decisions.
Well, I think that's great. And I'm sure, Elizabeth, that you would be such a wise person that people would turn to. And I know you have a new role at Queen's, which is lead of innovation. So I'm sure you're still very much involved in sort of leading and mentoring the next generation. So thank you very much for this conversation today. It's been really fun and a lot of insights over your career, over clinical trials, and over just how to follow your nose in research. So thanks very much, Elizabeth.
Thank you.
So there we go. That was a great conversation. I'd like to thank you, the audience, for tuning in to this first event of Gairdner Science Week 2021. I'd like to take a moment to thank our sponsors for their support for this event and for Gairdner Science Week as a whole. So to check out the full slate of our events, please visit the schedule section of Hopin or on our website at gairdner.org. Thank you.